have missed ESHRE, don't worry, because I am going to give you a complete update on what happened in ovarian stimulation this year in ESHRE. They have come up with the guidelines for ovarian stimulation. So whatever you do in your practice, it is a good idea to know what is currently recommended. Ovarian response prediction. Let's start with this. To predict a high or low response, as we know, whenever we see a patient in OPD, the first thing we classify them is high, normo, or low responder. So either AFC or AMH is recommended. Age, BMI, basal FSH, basal LH, inhibin B, estrogen, progesterone, none of these are recommended for prediction of ovarian response. For pregnancy, again, AFC, AMH, FSH, LH, estradiol, progesterone, inhibin B, all of this together, none of them are supposed to be representative of pregnancy prediction. Only two factors are taken into account for pregnancy. One is the female age and second is the BMI. Coming to pre-treatment therapies, many times we see IVF doctors, even I use estrogen before ovarian stimulation in the antagonist protocol. ESHRE now has said that is not recommended. And how do you use estrogen? Is in the luteal phase. So this 0 is actually the beginning of the luteal phase. You can give estradiol valerate 8 milligrams daily and add progesterone for the last 5 days, that is natural micronized or any progesterone, and then when the menses start, you start gonadotropin. So this is for better synchronization of the oocytes, that is not recommended. Pre-treatment with progesterone before stimulation is not recommended. Now I want to distinguish between pre-treatment and PPOS. This is a picture of PPOS, that is progesterone primed ovarian stimulation, where you use progesterone with the ovarian stimulation. So ESHRE is not talking about this. We are talking about pre-treatment before you do ovarian stimulation. Estrogen priming, what does Cochrane say? That it is associated with increased egg retrieval but also increased gonadotropin use, because especially poor responders will experience an early luteal phase rise of FSH, and estrogen priming will attenuate this and thus make all the follicles synchronous. Progesterone pre-treatment, because it reduces the number of ovarian cysts, is associated with higher clinical pregnancy rates. So here there is a little bit of dissociation between ESHRE and the Cochrane review. Estrogen and progesterone pre-treatment, according to ESHRE, you can use it, but more helpful for scheduling purpose. For example, if somebody wants to postpone their period or start at a particular time. What about birth control pill? Not recommended in antagonist protocol with FSH alone because of reduced efficacy. And why? Because we know OC pill will reduce FSH and LH both. So if you are using FSH alone, then OC pill treatment is not recommended. And if you are going to use OC pill, give a washout period of 5 days. You know, I attended the conference just 1 week ago. अभी हमारा ISAR embryology हुआ था. And Jaideep Tang, Dr. Jaideep and Pradikshit Tang, they travel all over, and they were saying in their practice, they have found that if the washout period you give as minimum 7 days, your pregnancy rates are very high. So the take home message is, if you are using birth control pill, pay attention to the washout period, keep it minimum 5 days. And how many days the patient has to take the pill? Even 12 to 16 days is enough, but washout period has to be there, minimum 5 to 7 days. GnRH antagonist pre-treatment, not recommended. What is GnRH antagonist pre-treatment? Sometimes from cycle day 2, we don't start gonadotropin. We will start GnRH antagonist because we see the follicles are not synchronous. This is also called as delayed start. This is not recommended. What about HCG? Sometimes HCG was used. Do you know how HCG was used? This is called as pre-IVF androgenization. 2,500 units was given weekly, twice a week, along with letrozole, transdermal, androgen. So according to ESHRE, this probably only HCG is not recommended. What about stimulation protocols? Now talking about high responders first, the delayed start, the one that I mentioned before, is not recommended to reduce the risk of OHSS. No evidence for natural cycle or modified natural cycle, but you should reduce the gonadotropin dose to reduce OHSS. And antagonist protocol is preferred in high responders, but if you are using GnRH agonist protocol also, it is okay. We had talked with Dr. Jatin Shah, and he's always doing agonist protocol, even now doing agonist protocol for almost all patients. Reduced gonadotropin dose is recommended. Then we have stimulation protocol in normoresponders. Delayed start is not recommended in normoresponders over conventional gonadotropin dose. What is delayed start protocol? Again, in delayed start, you start FSH later. You can give antagonist, you can give progesterone before or estrogen before to synchronize the follicle and then start FSH. This is not recommended as per ESHRE. What about normoresponders? Neither reduce nor increase gonadotropin dose. They say conventional dose 150 to 225 they are recommending for normoresponders. In low responders also, to synchronize the follicle, delayed start is not recommended. In low responders, modified natural cycle is also not routinely recommended except if it is very poor ovarian responder. I mean, if you have only one follicle in each ovary, very poor reserve, then you can go for a modified natural cycle. What is modified natural cycle? In which you give clomiphene or letrozole and one dose of antagonist and then trigger. Then we have stimulation protocol for low responders. Now we tend to use high dose, but what they are saying is that higher dose is not recommended. 150 to 225 is recommended, and in all circumstances higher than 300 is not recommended for low responders. What about pituitary suppression, agonist, antagonist? If you use agonist, long protocol is preferred over short or ultra short protocols. If you use antagonist, then you are using the preferred protocol. This is preferred over agonist protocol because you have both are equally effective, but antagonist has high safety because it can prevent OHSS. When you are using antagonist, do you use flexible or fixed? Flexible means starting antagonist when the follicle is 14 millimeters and above. So both are all right. I always use the fixed because you never know, sometimes in one day the follicle can grow quite big. Pituitary suppression regimens, if a freezole is banned, then you can use progesterone for pituitary suppression. That's the same as antagonist. That means this is the PPOS protocol. What about gonadotropin? You can use recombinant FSH, HMG both equally. RFSH and purified FSH in agonist protocol, both are the same. RFSH or highly purified. So you have three categories: purified, highly purified, RFSH. So recombinant has been compared with both purified and highly purified in agonist protocol. They are equally recommended. Now we all know that there is a new brand which has come, which has recombinant FSH with recombinant LH, the most expensive gonadotropin in the market today. So if you compare that with recombinant FSH alone, equally recommended for the general population. Specifically, that brand is marketed for low responders, but if we see ESHRE guidelines, they say that both are equally recommended. Combination of RFSH with RLH versus RFSH alone are equally recommended even if the woman is more than 35 years of age. Then the combined use of recombinant FSH with HMG, because generally what people do, even I do this, after 5 days of RFSH, I switch to HMG. So what is being said in ESHRE is this is not recommended. You can continue with recombinant FSH only or HMG only. The long acting or daily, there is a long acting corifoliotropin alpha. Unfortunately, it never made it to India, but long acting or daily recombinant FSH is equally recommended. Polytropin delta or alpha beta, that is the two big brands which are there, both of them are equally recommended for ovarian stimulation. Highly purified FSH versus HMG. So we saw that there is no difference if you are using FSH versus HMG in agonist protocols. RFSH and RLH is not recommended over HMG in GnRH agonists with regards to safety. Adding low dose of HCG to FSH stimulation is not recommended. Stimulation scheme started with gonadotropin. Some people do this. They start with gonadotropin, poor response, switch to letrozole. This is not recommended. you can continue with only gonadotropins. And addition of letrozole for high responders is again not recommended. Addition of letrozole is not recommended even for normal responders. Additional of letrozole to gonadotropin in stimulation protocol is not recommended even for poor responders. And there is no evidence to recommend the substitution by FSH by clomiphene citrate. Addition of clomiphene citrate to gonadotropins is not recommended for high responders, not for normal responders, and both of them, either clomiphene alone or in combination with gonadotropin or gonadotropin stimulation alone. All of three are equally the same when we talk about low responders. Adjustment of dose. Many times we do this when we switch from one FSH to HMG, we increase the dose. During mid stimulation is not recommended. So what is important is your starting dose. Pay attention to that. That should be appropriate. What about adjunct therapies like metformin, especially in antagonist protocol for women with PCOS? It is said that the routine use is not recommended. Growth hormone, before and during, I used to use a lot of growth hormone, but I have also stopped now because the company itself says that we don't recommend it. So growth hormone is still being used by a lot of doctors. I've attended recent webinars in South India. There were some people presenting who are using growth hormones, but as per ESHRE, it is not recommended. Use of adjuvant growth, testosterone, again, not recommended for low responders. DHEA before and during ovarian stimulation, not recommended for even normal responders or low responders. Aspirin before and during ovarian stimulation, not recommended for the general IVF-XC population for low responders. Sildenafil during ovarian stimulation is not recommended for poor responders. Myoinositol in PCOS, till now, myoinositol has not been come into the recommended category. So again, it is said to be still more studies are required. Again, low responders also, myoinositol can be used because of effect on egg quality. You know, I had recommended one patient and the patient came and told me, another doctor told her it is only for PCOS. It is not like that. Myoinositol can be used for poor responders also, but the evidence is still considered to be non-conclusive, and it is not recommended in non-PCOS women. Now, what about non-conventional ovarian stimulation? For example, random start protocol. Random start means you can start the cycle at any time because there are multiple waves of ovulation, at least 2 to 3 waves. It can be used if you are not doing a fresh transfer and there is no possibility of natural conception. Luteal phase start of stimulation can be used when the fresh transfer is not intended and there is no possibility of natural conception. Late luteal phase start of gonadotropin with fresh transfer is not recommended for low responders. Double stimulation you can be considered for urgent fertility preservation cycle. What is double stimulation? That means you would give a trigger and do egg collection, give a gap of about 4 days, and then start the injections again. Now here, there is a big question whether you will puncture the smaller follicles or not. And in the last conference, I had asked this question. We had a very prestigious speaker, and I had asked Dr. Abha Majumdar, and what she was saying is that sometimes they will puncture, sometimes they will not puncture. So it is up to you. But in generally, I don't puncture the smaller follicles, and I leave them to grow for the next cycle, and we do get competent embryos. Then we have non-conventional start of ovarian stimulation with double stimulation to accumulate the oocyte. This is called as accuvate. So it is again the same thing, but we are accumulating oocytes and embryos. Again, when we talk about fertility preservation, irrespective, this is a non-conventional start. Remember, this patient, when they come to you who are facing cancer diagnosis or need gonadotoxic treatment, they are not going to wait for even a day. If you tell the patient come on second day of the period, they will not wait for that time. So that is why these protocols have been developed, that you can start it any day, irrespective of the menstrual cycle phase. For women seeking fertility preservation for medical reasons, antagonist protocol is recommended. If it is an estrogen sensitive, like estrogen sensitive breast cancer, you must use something like letrozole or tamoxifen. How is it used? 2.5 milligrams, start from day 2 of stimulation and give it till the day of trigger. For final oocyte maturation, now this is different. Remember, when you're doing just egg freezing, it is different than embryo freezing. Because if you're doing oocyte freezing, you need mature eggs. When you're considering embryos, you can culture them, wait for it to, even become M2 and then fertilize. But you have to aim for mature oocytes if you're doing oocyte freezing. And in this cases, it is said HCG is preferred unless you have the risk of OHSS. And you can start ovarian stimulation for elective oocyte preservation also, irrespective of the menstrual cycle phase. GnRH antagonist or progestin is recommended over agonist protocols when you're doing oocyte cryopreservation. And the newest kid on the block has now come, elagolix. So they are not talking about elagolix, but probably it is one of the cheaper options that can be used, like GnRH antagonist orally. Then for oocyte cryopreservation, HCG is preferred unless the patient is at a risk of OHSS, in which case you can use an agonist trigger. And this was a complete summary. Thank you everybody for a very patient hearing.
Thank you, Dr. Shivani. That was such a crisp and very interesting talk. You have covered such an elaborate topic. And I would request, I think R.K. sir is there, Sharma sir is there. I would request Sharma sir to give his valuable comments.
No, excellent. Actually, this is all ESHRE, guidelines, so hardly anything to be added. Only thing is, what is your experience of dual stimulation with MPA? Instead of giving the first cycle, okay, you give antagonist to downregulate, and immediately after the pickup, put the patient on MPA and keep her on the MPA only, and then after 4 days do the stimulation.
Yes, sir, I am always doing that. You know why? Because if we don't give MPA, the person is going to get her period in between. Because if you are given agonist trigger, definitely the period will come before your egg collection. So you have no choice, you have no option. Even if you want to use antagonist, you still have to give MPA along with it. And if you are giving MPA, then of course antagonist becomes superfluous. You don't need to give it.
So it becomes more patient friendly, Otherwise, she has to take care.
Correct. And it reduces the cost also. Otherwise, patient will say, "Madam ने बोला एक ही बंद में दूसरा भी payment करने का है," so they get so it is cost effective also.
Yeah.
Shivani, it has been absolutely wonderful, and I feel this kind of an exercise you should be doing it every 6 months, and so at least you find it is ingrained in people's mind that this is what is not recommended. I am absolutely glad that so many things, the options have been written off. And I'm sure in ESHRE, whoever is suggesting guidelines, they must be real gurus to recommend it all over the world.
Thank you, ma'am. Yes, they have this guideline development group and they look at really high quality data.
Dr. Shivani, I just wanted to know, since you said that after FSH, on the 6th day, you would routinely add HMG, switch to HMG completely. Now, what are you doing otherwise after this talk?
Well, I'm continuing my protocol only because, of course, patient population is also different for us as compared to what they are dealing with. So I feel that this suits
and I think it is time tested, isn't it? It's a time tested protocol. We have given so many patients, isn't it? And the books also say that LH is needed in the mid-follicular phase.
It may not be superior to do this, but definitely it is not inferior. So it is not that this is something which is inferior. So I am sticking to my protocol.
Sure, thank you. Very nice.
Thank you.
So this is time to wake up and understand that HMG is equal to recombinant FSH,
yes,
which will reduce cost, and we are a poor country. So in tier 2-3 cities, many people can be benefited. So we must change our practice. And just
actually, more than India, the patients are very poor in front of doctors.
Yeah. And
Country is
we
rich.
must understand adjuvants, they are used, they should be used basically in interval period when patient doesn't want to go for, not along with IVF. All the recommendations are not to use them. That will increase further medicines, and one patient cannot eat more than a limited number. I have seen patient eating 10 tablets daily. And third thing, just I want my curiosity, anybody can answer me, that why HCG trigger is preferred for oocyte freezing. What is the ma'am or sir or Shivani?
Sir, आप बोलिए. I think the final maturation with the HCG is much better, much better.
You are likely to get more mature oocytes to freeze because there's hardly any time, especially in the malignancy cases. So you want to have as many as M2 oocytes. So we know that if we give agonist versus SCG, the SCG gives a more number of mature oocytes, and it is not only the the nuclear maturation is more, even the cytoplasmic maturation is also more in these cases. So subsequently, when you be making embryos out of it, the quality of embryos will be good.
So, sir, do you think these days everybody is using agonist and then freeze also? We are not doing the right thing. The quality of oocytes what we are getting after agonist is not
that. When you are giving, you should select which patient you would like to give long protocol, which patient you would like to give antagonist protocol, and then which patient in the antagonist protocol you would like to give agonist trigger or you would like to give SCG trigger. Isn't it?
Very clear.
So, or like suppose the eggs are less in number, so you would better give SCG to her. But the eggs are too many and OHSS is now a forbidden word. So you would like to give a agonist as a trigger.
So we should incorporate in our practice to have only adequate number of follicles so that we can use HCG, which will give better quality of oocytes and the pregnancy rate.
Especially if it's a poor responder or you are not getting more than, you should have a cutoff. So around 8 to 10 eggs you are getting, you better give SCG. Anything more than that, better give agonist.
Correct. Especially, oocyte freezing is a bit different, and egg collection, like normally it is done 34 to 36 hours. But if you're just doing elective oocyte freezing, it's better to do it exactly at 36 hours because again, that is going to give you more mature oocytes, so that the ultimate objective is a pregnancy. So that is why egg freezing is a little bit different than the conventional stimulation.
Yeah, and moreover in the lab also, I always tell them, just don't denude the oocytes immediately. Wait for 4 hours.
Exactly.
Some oocytes can get mature in your lab also.
वही सर बहुत डिफिकल्ट है वो एम्ब्रियोलॉजिस्ट को उधर बिठा के रखना कि पेशेंस रखो कि आप अभी मत डिन्यूट करो.
Yeah, that's very important in these cases.
I think all of us must understand that embryo freezing is very different than egg freezing. Yes. I think the protocols are different, and when it is mandated that in case if it is possible and there is no evidence, no likely that OHSS mein patient jayegi, so it's good to give HCG trigger. And very rightly, Dr. Shalini said that you have to see to it that perfect timing of 36 hours are taken, and there's a delayed generation is there of the eggs. I just wanted to know, Dr. Shivani, what is your take on the egg which has been frozen? When they come back, what is the usual protocol in case if they want to have a pregnancy?
Ma'am, I missed in between. What did you say? Protocol for who?
Right. See, the question is the egg is frozen. So 5 years down the line, she comes for the pregnancy. By that time, she has a partner and things like that. So how do you do when you are planning it for pregnancy?
Then I generally do initial tests and I start her on the frozen embryo transfer protocol FET with HRT. I'm using hormone replacement, but I prefer to take the husband's fresh semen sample. I spoke to Brigadier Sharma, sir, how to maximize. Sir ने बोला कि frozen में success इतना अच्छा नहीं है तो fresh use करो. So then now whenever the husband is available, I call them at the exact time, and हमारा embryologist time भी देता है कि this is the time I'm going to thaw and this is the time I need the husband to come for the semen sample. So I prefer it that way.
We can also go for a natural cycle transfer in this case, because if the other things are normal, then we can go ahead and do a natural cycle transfer. And the day we start the progesterone, that is the day we do the ICSI.
and then plan a transfer 5 days later.
Only problem is for natural cycle, no, you have to see the patient more frequently.
Yes.
Like,
Yeah.
and the risk of cancellation is little higher. So
If the patient is having absolutely normal cycle in a rhythmic pattern, then her body is like, much better in a receiving mode with a natural cycle transfer.
correct,
Yes, I
correct.
agree. We might need to see frequently, but frequently we need to see only when there is a poor ovarian reserve. If she is a normal responder, normal young, like female in her 30s with natural rhythmic pattern, 28-day cycle, so then we can plan natural cycle transfer for such cases. The benefit is that let's assume worst case scenario, we do not have any embryo on day 5. Like it may happen that we froze the eggs and there is no embryo. In that case, we have not given anything extra. But yes, we have to individualize which case we can go for
And I
natural.
don't think they mind any extra. They just say do whatever. We just want a positive. And
See,
secondly, yes,
actually, what we are, I think, confusing a little bit. So we were talking about the onco patients where we have done the cryopreservation.
Okay.
So there'll be two situations in that. One,
Yes.
she is ovulating regularly. If she's ovulating regularly, they use the AMH, and maybe she can conceive
Naturally also.
actually also. But if the AMH is low, that means she's not ovulating. There we won't be able to do the natural cycle. So
Then we cannot
that
do. Yes.
has to come. So
Yeah, it can
preferably,
be
if an
chemotherapy.
AMH is good after the because nowadays the onco treatments have become quite effective and not that toxic to the ovaries. So under those circumstances, we can also encourage them to go for a natural if everything else is okay. Or if the
Yeah, very
AMH is
rightly
low,
said, sir.
we can ask them to do the fresh IVF and keep these oocytes as a for future requirement in case yeah.
Plan B.
Yeah.
Yes, so we really had a great discussion. And Dr. Shivani, I really would appreciate that you have really brought this point very clearly. All this literature and everywhere, and so many people are, confused that they read this, that giving birth control pills in the previous cycle decreases the result. But I'm glad you have taken this point out. And definitely there is a washout period of 7 days. So if we start the stimulation, like we have given the birth control pills in the previous cycle, and if there is a washout period of 7 days, the results are same, I think.
yes,
Because
yes. Wash
at
out.
one, yeah, yeah. So I think that's a very important take home message for all the listeners.